presentation that our presentation that we do every week is for educational purposes only. If by any chance you have any concerns regarding what we discuss week after week, we would like for you to discuss this with your doctor in case you need any further treatment. We are not here to treat, diagnose. We are only here to give information. So whatever concerns you might have, please discuss it with your doctor. Today we have Dr. Sinclair who will be discussing about breast health for both men and women. So today I want to welcome Dr. Sinclair to our platform once again. It's such a joy to always have you and for you to share the knowledge that you have with our audience. So without any further ado, we are going to go ahead and listen to Dr. Sinclair, what she has to say to us today. Welcome again, Dr. Sinclair.
Thank you. Sister Evelyn, can you pray for us, please, before we start?
Oh, definitely. Heavenly Father, we thank you for this wonderful opportunity you have given us where we can come together and to share ways in how we can take care of our bodies. I do pray for Dr. Sinclair. She presents today. Give her the words that you want her to say to us today and help us as an audience that as we listen, we will take into consideration what she's saying and so we can live it out in our lives. Bless this platform and continue to be with the leadership of this platform. I do pray in Jesus' name, amen.
Thank you for having me once again, and thank Dr. Sankey. Thank you for your patience. I was supposed to speak last week. A friend of ours died suddenly. So last Sabbath afternoon, we were actually at a funeral. And thankfully, I was able to do this week because I hate to miss these appointments because I know that they're so important. I want to, I'm going to need to share my screen. And let's see, which one is it? This one. We're going to start with this one. Okay, and we're going to start with our slideshow. Okay, so the title is Breast Cancer Facts or Fiction. I've added some additional slides. Some of you have heard it before. There's also some new information that I am going to be sharing today. It's the second most common cancer in women in the United States. The first being skin cancer. Now, of course, skin cancer is much more common among Caucasians and seen that they're the majority population. But in many other places in the world, especially outside of Europe and Canada, much of the Caribbean, Central American countries, breast cancer is the #1 cancer because they don't have the problem of skin cancer. But it is treatable with excellent results. And we do talk about the fact that breast cancer can occur in men. In fact, this week I had a wife of a patient of mine who I treated many years ago. He didn't die from breast cancer, but he had breast cancer. And interestingly, his mother had breast cancer. These are older folk. Well, the wife is in the 80s now, and he passed a couple of years ago. Like I said, he didn't pass on breast cancer, but he did get breast cancer, and it was hereditary breast cancer, just like many women get. So about 6% of all the breast cancer patients occur in men. And we just need to be aware of this, that if there's no such thing as a normal lump, even in a man's breast. I mean, their breast is not as developed as others. We know that because they don't lactate or they don't bear children. But there's certainly, if there's something awry, then it should be evaluated. Now, it's just under 300,000 cases per year, about 44,000 deaths per year, and about 70% will die. 80% will go on to live their lives. So you see, majority of the patients will live. And those are the patients who receive treatment. Part of the reason why the rate of the survival rate is not higher is because there are people who get diagnosed and don't wish to be treated. Of course, some people get diagnosed later, and as I'll show in a slide in a little while, you see that the early diagnosis does lend towards excellent outcome. There are two major categories of risk factors. Some are unchangeable and others are changeable. The unchangeable risk, being born female. I know we hear a lot in the news now about transgen, etc. They're actually a very, very small minority, even though sometimes you think that they're a much larger minority by what you hear on the news. But it doesn't matter what you decide as you get older, whether, you know, we're not going to discuss that right now, but the fact of the matter is being born female increases your risk of breast cancer. As we get older, there's also increased risk of breast cancer. And these are actually the two highest risk categories. Family history of breast cancer is the next major risk category. It can bump your risk up to 22 to 25% increased risk. And the family history has to be on the maternal side. So if it's your mother, your maternal aunts, your sister or daughter, those, you know, first degree relatives or multiple second degree relatives. So let's say your mother doesn't have breast cancer, but all her sisters have breast cancer and their daughters have breast cancer, then there is a genetic risk there. It may not have been shown in you because not all genes manifest themselves. The exception to the maternal family history is people who are BRCA positive. And it's not just BRCA, that's the most commonly known gene, but there are actually several. There's actually a gene pool of genes that we look at for patients who are at risk of breast cancer. So if your mother, as with this patient that I was telling you about, his mother had breast cancer and we didn't test him. This was some years ago when he was diagnosed. But he did, I think later on he did get tested and he did carry the gene. So even if you have a woman with breast cancer and you test positive for the BRCA or any other breast cancer gene, even your sons are at risk. And even though they're at risk, and if they have daughters, they're at risk, because when a child is formed, when the fetus is formed, half of the genes come from the mother, half of the genes come from the father. We don't know for certain that a child will get the cancer gene. It's not a dominant gene, so we don't know. The only way to know if you have the gene is a test. One of the things that people don't realize is that the positive gene is not just for breast, it's for ovarian. And actually breast cancer is relatively easy to treat for the most part. There are a few exceptions. And it's ovarian cancer that's more deadly. But of course, the breast is very visible and it defines us who we are as women. And that's the one that most people are much more concerned about, even though it's not nearly as deadly as ovarian. So positive BRCA has a lot of implications for a woman or even a man. He doesn't have to worry about ovarian cancer, but he does have to be concerned if he has daughters that he could have passed a gene on to them. The other thing is breast density. And I'm going to show you some pictures of mammograms in a minute. Now, breast density, we used to just think it was a variant, you know. We're all different complexion, whether or not, even if we're Black or white, none of us are like the same complexion. So we used to think years ago that a density on a mammogram was just like having blue eyes versus brown eyes versus hazel eyes. But what we found out is that dense mammograms are, those patients with dense mammograms actually have a higher risk of breast cancer. The reason we didn't realize that at first, because dense mammograms are harder to read, and I'm going to show you some pictures soon, than a fatty replaced mammogram. But we thought it was just, that's the reason we weren't finding the cancers as easily. But after looking at that as a factor and looking at thousands of patients in the US, Europe, and partially taught by ethnic groups, etc., we realized that this is a marker. It's actually, it's not anything you can do. It's just a fact. Meaning like if you're born with blue eyes, you're born with blue eyes. There's nothing you can do about it. But that in and of itself may increase your risk of something. If you're Caucasian, you do have an increased risk of skin cancer. It is what it is. Well, women with dense breasts are at increased risk of breast cancer. So when we look at those women with mammogram now, we're more likely to order additional tests like ultrasounds, et cetera, because we realize that they're at increased risk. Now I'm going to pause here to talk about genetic testing in general. Recently, we started working with someone who, and actually several, we did some at Mount Olive, but North Orlando actually has a clinic the fourth Sunday of each month, and they have been doing testing on a regular basis. And we have been finding patients with positive for several of these. And we have also found patients positive for other cancers. Like I had a patient, even though she had a family history of breast cancer, she actually tested positive for skin cancer. And of course, you know, looking at her ethnically, she looks like me, but phenotypically, she actually has a lot of Caucasian heritage in her family. And because of that, she actually has a propensity for skin cancer. And she was able to use this information, see a dermatologist, do a survey, and get closely monitored, which is not something someone who looks like her would normally do. So the panel is not limited, it's actually a scope panel, but these are the ones that can be tested for: breast, prostate, ovarian, colon, and pancreatic. We used to, with breast, it used to have to be, you had to have breast cancer before the age of 50. Now we just test, period, because we're finding out that that was too restrictive. Many of you know about the star of Wakanda, Black Panther. He died from colon cancer at age 43, which, even though I don't know his medical history, I'm sure he had a genetic component, because even in high-risk patients, we don't start testing until age 40. And for him to die at age 43, that means that he had metastatic cancer. So he definitely had a genetic component. Pancreatic cancer is something we know all too well. I know several people in our churches who have had this, and the test also looks at panels that will see this. And of course, the ovarian cancer, which is much more deadly than breast, and prostate cancer. If you have a history of prostate cancer in your family, the test can be done. I'm just putting this plug in here. I don't get any financial reward for the test. The test is covered by most insurances, and they do have plans to help persons if they're uninsured or underinsured in order to cover it. And if your insurance rejects the claim, they actually have a very good program to still get it paid for. So it's something that you can do. I don't know everybody's history, but like I said, I know North Orlando does it with their clinics every month, the fourth Sunday of each month. And there are other ways in which you can get the test. It's very important, because if you're positive, there's a lot of things that you can do rather than this thing just coming upon you at a time in life and being as disruptive, because cancer can be very disruptive to families. Okay, now we're talking about the risk that we can actually do something about. I did a program recently on cancer prevention. And as I was preparing my slides, one of the things I noticed is that I started to compare cancer to diabetes, because the prevention strategies for treating diabetes or reversing diabetes are exactly the same for the most part, much of it, as breast cancer, because this here at the top is the #1 controllable factor that we can do. Obesity and high-fat diet is good for nothing. It's increased risk for colon cancer, breast cancer, heart disease, diabetes, and these are actually things that kill people much more frequently than breast cancer. Exercise daily, maintaining a healthy weight, and rest, those are the things that decrease your risk of breast cancer. It's not to say it eliminates it, because I tell people all the time, yes, I do get patients who come in who are very healthy and they have breast cancer, but remember, we still live in a world of sin. That doesn't mean that because we're in a world of sin, that doesn't mean you're going to do whatever you want. You're going to still do what's best for you in terms of preventing all kinds of disease. Alcohol and tobacco. Tobacco is associated with just about every cancer there is. Alcohol actually increases the risk of breast cancer. Menopausal hormonal therapy. Let me give you a little backdrop on this. Back in the 80s, the doctors noticed that women had lower risk of heart disease, but after they hit menopause, that risk went up. So someone got the idea, okay, when a woman is going into menopause, let's give her hormones so she stayed in a non-menopausal state. But we're fearfully and wonderfully made. And there's a reason why God had us stop menstruating and become, even though they call it menopause, we're the ones who really pause. We're the ones who had the change, or the change, as some people say. Not only did hormonal therapy not decrease the risk of heart disease after menopause, it actually increased it. And there's another bad side effect that happened too, and that was an increased risk of breast cancer. So that is not to say you cannot take hormonal therapy. There's some people who have had early hysterectomy and other things, and they're just not able, their body is just not able to adjust, and they may need some hormonal therapy. But we really started to restrict hormonal therapy many years ago, because we realized that, number one, it didn't benefit what they expected to happen, didn't happen. In fact, the opposite happened. And of course, the increased risk of breast and uterine cancer, which was why we give some limited in special cases, but it's no longer given out. It was almost given out like, oh, you turned 50, here's some Premarin, which, by the way, is pregnant mare's urine. It was extracted from pregnant horses. Anyway, that's just a side story. Radiation treatment. Now, I always have to explain this. This is not your mammogram or even a simple chest x-ray or even a CAT scan. These are things that happen every once in a while. Radiation treatment occurs when we have young patients who had Hodgkin's or non-Hodgkin's lymphoma, thyroid cancer, or other cancers that cause them to have radiation as part of their treatment. These, mostly women, a few men, do have a high risk of breast cancer. The breast cancer is usually very early, it's carcinoma in situ, and usually treated early. It rarely ever goes on to the point where it's gonna cause the demise of the patient. So if you have a young person and you have been diagnosed with Hodgkin's or non-Hodgkin's lymphoma, it's not for you to not have radiation treatment, because it's going to be life-saving, and it's only a small percentage. You just know you have to be much more careful, get mammograms earlier, be monitored for that. The things that decrease our risk: exercise and maintaining a healthy weight. Cannot overemphasize that. Exercising routinely and maintaining a healthy weight. And I should add to this, get enough rest, because if we don't get enough rest, we don't allow the body to recharge. Sister Emlyn and some of the others who have been on here regularly know that we just talked about that the other day. And we talked about it back in April too, because I'm struggling with that. So pray for me. I need to get more rest. I definitely do. You'd be surprised the thing that not getting enough rest does to you in terms of your blood pressure and other things like that. Early pregnancy, meaning that the cycle between when you first start seeing your period and the time you get pregnant. Women who get their first child in their 20s have a lower risk in general than those who have their first child well into their 30s and even 40s. Breastfeeding actually decreases the risk. They have all stories back and forth, but breastfeeding actually decreases the risk of breast cancer. And this is not looking at a few patients, looking at thousands of patients. Some of the things that we hear all the time: deodorants cause breast cancer, mammograms cause breast cancer, large breasts increase the breast cancer, vegetarians cannot get breast cancer, and there's a slew of others. Every time I think I've heard it all, somebody comes into the office and tells me something else that they thought was going to prevent them from getting breast cancer. There's no bush tea, there's no herbal medicine that can prevent you from getting breast cancer. Vegetarians, lifelong vegetarians, not vegetarians, but vegetarians, actually, it is rare and just extremely unlikely that they can get colon cancer. And also for prostate cancer, they've found that with some prostate cancer, especially those who get prostate cancer very late in life, choosing a vegetarian vegan diet actually decreases the risk of prostate cancer for those who get it late in life, not the ones who get it earlier. And it also improves their outcome. So there are advantages to diet, but there are also limitations. It's not curative, it just improves their outcome. Mammogram saves lives. It's a fact. Before we had routine screening, we were finding lumps. Even when I was in medical school back in the mid-'80s, most of the cancers we found is because somebody felt it. Either the woman or her husband or boyfriend or somebody felt it during intimacy. And of course, the rate of detection, it was always a later stage. And the survival, as you can see here, it's not rocket science. If you have, this is just when there's some cancer cells lining the duct. This is when there's actually a tumor that is visible on ultrasound, maybe even small but palpable. Stage 2, you have a palpable tumor. And stage 3, it's starting to spread outside of the breast. And stage 4, it goes outside of the breast and outside of the armpits, outside of the axilla. It's not rocket science. It's just simple mathematics. The bigger the tumor, usually the worse the survival. There's some other nuances we look at too, to tell whether a tumor is more aggressive than the other, and that can also affect your outcome. So with mammograms, we have early detection, early biopsy, early treatment, and excellent outcome. And before, I should have said this before, but even if you have a negative mammogram, if you feel a lump, you need to be evaluated. The mammograms have gotten better. Some of us are old enough to remember when we had black and white TVs, when Technicolor came in. And then some of us are also, many of us are old enough to remember when we switched from just analog to digital TV. I remember the first digital TV I had, that thing was so big and heavy. Now I have a TV that's bigger than that, and it's so light. Except for the bulkiness, I could lift it up by myself. So, and you look at the picture, sometimes the picture, it's almost like the people are coming out the screen, as opposed to when you look at old movies on an old TV. So because of that, the mammogram got much better, still not perfect. Why? Because it can only do but so much. So this is a picture of your breast anatomy. You see, it's fat, and then we have these lobules, and they go down to the duct. This is a blow up of the lobules. So we have two places where we get cancer, two main places. There's some other cancers like papillary, et cetera, which are much less common. But the two main ones, in fact, the main one occurs in these ducts. And what it looks like on a mammogram is like when a stone hits your windshield and you see that burst, and then you can see spikes going out. That's kind of what it looks like when we see a mammogram. Lobular carcinoma is problematic because it starts in the lobule, and so it tends to be round and pushes the tissue out of the way. And sometimes even the best radiographer is not going to detect it until it's larger. And that's why it's still important for you to do your breast exam and not just rely on the mammograms. We have other things like Paget's disease, where you have what looks like a rash around your breast and it just won't go away. And it's actually a sign that you have a cancer. And then there's inflammatory, which looks like an infection. You look like you have cellulitis, redness of the skin. And we have a term called peau d'orange, which means your skin looks like an orange peel with the dents. That's a very, very aggressive cancer. And you could have had a mammogram like 2 months ago that was normal. And then you notice the change in your breast. It needs to be taken care of and see a doctor right away. These are examples of normal mammograms, okay? This is the friend of the doctor. You don't have to have much training. As you can see, this is a fatty replaced breast. Anything that's in there, I can find. I'm going to show you some samples of breast cancer in a minute. Here, we start to have a little what we call fibroglandular densities. Of course, something could be hiding here, and we can't tell. Then we have a more dense breast, you know, And again, if you're looking at it, if the cancer is in there, you may or may not be able to tell it. This is a normal breast, by the way. But you see the difference between this breast and this breast? This breast is so dense. Now, younger women in general tend to have dense breasts, but once you start aging, usually more start to look like this. So if you maintain this dense breast throughout your life, it's a nightmare for the radiologist, but it's also an indication that you're at a higher risk. It's just one of those things. Nothing you can do to change it. It just is what it is. You just need to be aware that if they say you have dense breast, what we do in general, especially as the patient is getting older, and we know that they're still maintaining this dense breast and they're not converting over to something like this, is that we do additional studies like ultrasound or MRI periodically, because we know we can, even with the computerized evaluation, we will miss stuff. These are all examples of breast cancer. This one here, you see if you look carefully, you can see the spikes going out, but there's a central lump. Here you see some calcium deposits. Let me see if I can make this bigger. Oh, no, it went to the other page. Hang on. Okay, so you see some calcium lumps and you see a lump here. Just FYI, just a brief little lecture. Anything that occurs behind here in the breast is suspicious. Because even when you go back to the other mammogram, the normal mammogram, you notice that when you have densities, they tend to be here. Now, of course, this is dense everywhere, but even in this one back here tends to be a little lighter. So when you have anything we call this no man's land, anytime we see any spot, calciums back here, we're very suspicious. Because nothing is supposed to be back there but fat. This is a lobular carcinoma. You notice how it's nice and round. A lot of times, unfortunately, we don't detect these right away. But a woman may feel a lump. And that's why I said, if you feel a lump, you need to get it checked out. Every few years, I get a patient who have had a normal mammogram, but they felt it and they felt a lump. And I can feel a lump because, there's some women who always, my breasts are so lumpy. That's fine, still come in. But they're always feeling lumps. But if you feel a lump, and the biggest thing too is you feel both of your breasts. And even when I examine patients in the office, they'll say something's on the right, I start with the left. The breast is not affected. Why? Because I want to see how that breast feels. And I come over here and I feel there's a difference. That's the reason for me to do additional studies and possibly a biopsy. And every few years, I get patients who had normal mammogram, normal ultrasound even. And yes, they came into me because they felt this lump and we did a biopsy and it's cancer, and it's never like early cancer, it's always like aggressive cancer. This is what it looks like on ultrasound. So when we have a breast like, let's go back up a couple of pages. When you have a breast like this, you can't really see anything on mammogram. But when you come down to here and you look at the ultrasound, you do an ultrasound and you can see, I should have had some normal ultrasound to show you when it's a cyst or just a benign lump. But when it's benign, it tends to look like a little marble, some sort of oval, maybe even a little dumbbell. The thing you notice about these is irregularity. You can't see a nice, good edge. You cannot see a nice, good edge. Whenever we see that, we even my staff, who is, I remember we had a young lady, she had just done a CNA course and she was helping out in the office. And even her, after I did a few biopsies with her, she could tell, she said, she called me and she was like, Auntie Carlene, that's cancer, right? And I said, I'm pretty sure it is. Because once you see these images all the time, you see a cyst just looks like a nice little black lake. It's smooth and so on. Once you see this jagged nature, you know it's not good. So once we've made it, and there are other things we do, MRIs and PET scans. Some of these are done in high-risk patients, patients who are positive for the gene, or patients who have strong family history. We may do that because we know that we're not going to pick it up as early as we would like to. Mammograms, the old adage was to start at 40. Then they came out with this thing about you don't need to start at 50. That really just came from the insurance companies. I'm telling you right now. But of course, then they had to backtrack. So they said, oh, you should discuss with your doctor. I don't know any doctor who you're going to discuss at 40, whether you're not choose to have mammogram, who's going to tell you no, because it's one of the number one cause of litigations is misdiagnosis. So they're going to tell you yes. Now, if you have absolutely no history and you have that nice fatty replaced breast, if you do every 2 years for a while, and then by the time you get to 50, you go every year, and we get into your 70s, you go back to every 2 years, that is somewhat acceptable, assuming you don't have any other risk factors. However, my thing is every year. I can't tell you how many people I've had who they missed a year for whatever reason, and not necessarily as big as lump as I showed you before, but that lump shows up because cancer doesn't just grow. It grows, sometimes it's latent, and then it has a spike. But the reason we do mammograms is because we don't want to wait for you to feel it. We want to be able to do early. That slide we saw earlier, the smaller it is, the smaller the stage, the better the prognosis. So once we do mammogram and ultrasound, we try to get some sort of biopsy. Some biopsies have to be done with mammogram. Most biopsies can be done using ultrasound. We may use these other studies if we're concerned of spread, or even like the lobule cancer that I told you about, is we call it 20% cancer. 20% is bilateral, meaning both breasts, the other breast will have another cancer in it. 20% is metastatic, meaning it's already spread in your body. And 20% is going to recur. And this also occurs in 20% of the breast cancer patients. So we call it a 20% tumor. So patients with lobular carcinoma diagnosis will do an MRI because we want to make sure that there's nothing going on in other breasts. The most common type of breast cancer is less than 3% of those patients are going to have a concomitant cancer. They may get another cancer years down the line, but to have a cancer at the same time are highly unlikely. And because we do mammograms of both breasts, we're much more likely to find it. I do have patients who come in who have had one type of cancer in one breast and another type in the other breast, and they had it at the same time. But that's more unusual. Surgery is the mainstay of treatment, whether we just remove the tumor, a lumpectomy, or we remove the breast. Radiation therapy is an adjunct to surgery, allows women to keep their breasts. Chemotherapy may or may not be necessary. It has nothing to do with whether you have a lumpectomy or mastectomy. If you need chemotherapy, you're going to need it regardless of what surgery you have. Same thing with hormonal therapy. It doesn't matter whether you choose mastectomy or surgery, lumpectomy with radiation. These additional therapies are based on other tumor markers we look at. They're not based on the size of the tumor. So this is something you're going to have discussed with your surgeon, with the medical oncologist, with the radiation oncologist. And while we know that chemotherapy can be very damaging to our bodies, cancer is even more damaging. So, we don't give out chemotherapy willy-nilly, only for those patients who we see a benefit. And there are other tests we do here, like the MammaPrint or the genotype DX, which help us determine more accurately who will benefit from chemotherapy and who won't. Now, fictional treatment. There's no herbal medicine that's going to cure cancer. Not breast cancer anyway. And there's no such thing as alternative medicine. There's medicine. Herbal treatments are not alternative medicine. They're medicine. So there's no such thing. The reason I don't have a strategy with dietary changes, because as I told you before, dietary changes are good for many things, including high blood pressure, diabetes, heart disease, everything else. So it's never too late to change and start a better diet and start eating healthier and change your lifestyle. That is never too late. I don't care whether you have cancer or not, it's never too late. But these things, let's be clear. I use herbal products all the time. They're not to cure cancer. There are a lot of things that it helps me with. Ginger and pineapple do very well for the stomach. Turmeric helps with arthritis. Soursop is good for high blood pressure, and papayas also good for high blood pressure. Cancer is like you got shot, okay? If you don't go to the doctor and let them stop the bleeding, and fix the problem, you will die. Now, if you get a graze wound and you don't do it, it may stay there and fester. You may die over time, as opposed to somebody who got shot in the heart who has to be treated immediately. It's like if you're in an accident, you break your leg. You can't just say, oh, I'm going to pray about this. I'm not claiming it. If you don't get that leg fixed, you'll forever have a limp, and you may actually lose your entire leg. If your house is on fire, you don't say, okay, I got the fire out in part of the kitchen, and the fact that there's the smolders in the garage, I'm going to leave them there and we're going to be okay. No, that's not what happens. Eventually, if you don't take care of the entire thing, it's going to burn down your house and it will completely destroy your body. That's what it is. It's like sin in many ways. It stays silent for so long that people think that, oh, I didn't have any pain. It can't be bad. Yes, it's bad. And if you don't get rid of it, it's going to just take over till in the end, you're gone. And all of these people who go to these alternative things, I can tell you, I don't know any of them who have been healed. I know no person who can testify to me. And even recently, I know some folk who, and they were desperate because at the time they had gone through all the medical treatment and the cancer. This wasn't breast cancer, was not a cancer, kept coming back, and they spent thousands of dollars. I mean, thousands of dollars. And of course, they're dead because those people cannot treat you. If you come to me and you ask me how many patients I've treated with breast cancer, what stage, et cetera, I can tell you. I can't give you their names, but I can tell you. I can tell you the outcome of the patients. These people cannot. There's nobody that they can tell you to call to talk to you about what their experience with chemotherapy is or their therapy, because they're not alive. And that's just the fact. So what do you need to do? Healthy lifestyle, low-fat diet, routine exercise, adequate sleep, monthly breast exam, follow same time each month, even if you're postmenopausal, same time each month. Don't examine your breast every minute. For the premenopausal woman, your breasts are going through changes. So postmenopausal, your breasts are more stable, but even so, different things can cause you to have some edema, some swelling, or whatever. So your medicines that you may be taking may be affecting it. So you try the same time each month. If you're postmenopausal, then you say the first week of the month, that's when I'm going to examine my breast. If you're premenopausal, a week to 10 days after your menstrual period is a good time to examine your breast. And do you do it every time? A week to 10 days after. And you choose that time. You go through the routine. You can go on any website to see how to examine your breast. There are pictures and diagrams how to do that. You follow a pattern. Yearly mammogram starting around age 40. You may have to start earlier. If you have a family member with breast cancer, you start 10 years before that person was diagnosed. That's a first degree relative. That's a sister, mother, or daughter. If you, or if you have multiple relatives who have gotten premenopausal breast cancer, you try to start about 10 years earlier. So if your mother had breast cancer diagnosed at age 45, you need to get your first mammogram at age 35, even if you don't test positive for the gene. Yearly checkups, yearly pap smears, because these things save lives. If you found a lump, there's no need to panic. Especially in younger women, the vast majority of those are going to be benign. Not everything that goes bump in the night is a problem. Most of those are going to be benign. So you make an appointment, you see your doctor, you get a mammogram, ultrasound. If you need to get a biopsy, you get one. If you're not satisfied, you get a second opinion. We are not panic people, okay? God says, I have not given you a spirit of fear. We're not supposed to panic and worry. And Jesus himself said, this is his words, what are you worrying for? Can you by worrying change one hair on your head? No, we can't. Do not think this magically go away. There's no such thing. With God, there's either magic or there's God, okay? There is no, the two does not come together. And don't start taking some herb that somebody told you about. I know two people that I can confirm, and there are others that I can't confirm, but two people I know confirm. One was very healthy and died. And I know because I got a chance to look at the CAT scan of the liver, and I know liver is the clearinghouse for your body. So everything you put in your body actually clears through the liver. And I know that death was a result of liver failure, complete liver, and some other things that were going on. Complete liver shutdown should not have happened. Person had no medical problems, normal weight, etc. But they just believe that they need to take herbs. And I'll tell you one more herb story. I went on a mission trip to St. Lucia some years ago. And a friend of mine, Gary, was there, and this tall, very beautiful lady, and she was tall, she was slender, and she was getting dizzy and passing out. So when Dr. Rule, when he took her blood pressure was so low. And so he was talking to her and he said, oh, she knows so many people with high blood pressure. So she started taking green papayas. And for those of you who don't know, green papayas, people cook them with meat and stuff. They're also a good meat tenderizer. But the other thing that they do is that they're like strong blood pressure medicine. And she was eating it like every day. It was like the vegetables she ate every day because she didn't want to get blood pressure. Well, guess what? Her blood pressure was bottoming out. And that's why she was getting dizzy and she was falling. So we told her, stop doing it. That's like you're taking medicine. You would not right now, if you don't have high blood pressure, if you don't have that, you would not take medicine for those things. Why do you think you're going to take a herb for something that you don't even know what she was trying to prevent and almost kill herself? So don't just take a herb and don't just go willy-nilly on the internet. I need to change it because there are internet sites that you can go to. Don't just go willy-nilly. Somebody's out there trying to sell you something and somebody's out there trying to make money. So, that's not where you need to go. You need to do what you do for everything else. You need to see a doctor. In our church, doctors are so respected. But when people have cancer, we don't know nothing. It baffles me every time because I've taken care of some of our people. We're very respected. Everybody in the church, they want their children to be doctor. Joanne is a music major, and I see it on people's faces. What's your major? Oh, music. Oh, she's not going to be a doctor? No, she's going to be a musician. Because that's what we expect, right? But when people have cancer, all of a sudden, we don't know anything. We can't let the devil use us like this. God put us here to treat everything, to high blood pressure, diabetes, gallbladder, everything else that you need. We're here because God gave us knowledge to help ourselves as well as to help others. This is what I meant about internet. There are several sites. There are a couple more, but these are probably the ones that you can, and you don't have to be in the country. You can, anywhere you go, we have internet access. You can access any of these websites. Cancer.gov is from the NIH. Breastcancer.org is from the American Society of Breast Surgeons. And there's one that I don't have on here, which is the American Cancer Society, ACS.org, all cancers. Komen, Susan Komen died many years ago from breast cancer, but she left an estate and she supports all kind of stuff for breast cancer. Sisters Network is actually a network of Black women with breast cancer. They match you with someone with a similar age, similar ethnicity. And it's not just for Black women, but it was started by Black women, and that's what it's called. They actually have offices in Tampa and Orlando. And basically, they are a support group. And people say, well, I have my husband, I have my children, they don't have cancer, okay? These women here, they have breast cancer. So they can give you information about things that I'm not going to even think about as a doctor. Right? So they're a good resource for you, or if you have a family member with breast cancer, they're a good resource for you in terms of just helping you get through some day-to-day things. Like, when I was going through chemotherapy and I was doing this, I tried this soap or whatever, and it helped me. These are the things that they help with, or just someone to talk to. You're wondering, my kids are just in elementary school, what's going to happen to them? Just someone else who has been through it, who can say, such and such and such. So they're a good organization to be a part of. And these organizations as well, Cancer.gov, Breast Cancer, and Komen, they also have support groups. And American Society has something called REACH, R-E-A-C-H. And basically it's for any type of cancer. And again, these are support groups. And like I said, it's true that we have a church, we have our church family, we have our personal family, but these groups are people who have gone there before. And why is the Bible so important to us? Because it's telling us about people who have gone through stuff before, right? That's why the story of Job is there. So when things are happening, you cannot figure out why things are so bad, you have the story of Job. That's what these groups do. They help you go through things, not necessarily that is curative for your cancer, but it helps you and your family deal with the diagnosis, because it's not easy. It's not easy diagnosis to accept. And just remember, most patients are going to live. If they allow themselves to be treated, they're going to live. They're going to live out their life. I have a handful of patients who have had recurrence, and they have not, with the one exception, and she was diagnosed in her early 30s. So I knew it was going to come back. There's just no way. I have a couple, one in 24, one 26, and one 28. Those women, those are aggressive cancers. I know that even though we do a lot and they're going to be blessed for a few years, the chances are they're going to be dealing with cancer again. But even so, they are the minority. The majority of patients are going to live out their lives. They're not going to die from breast cancer. They're going to die from something else. And even the ones who die from breast cancer, we're talking about 20 years down the line. A very good friend of mine, she was diagnosed in her 40s, and she had an aggressive metastatic cancer, 20-something years. And when I say she lived, she wasn't in a hospital, she wasn't in hospice. She lived to see her sons grow up. And they didn't get married or have any children, but that's on them. But anyway, she lived, she went on trips, she was not in a hole somewhere. And one very good friend of mine, I don't know if she's on, I gave her the thing. She's a survivor as well, and she does everything for people with breast cancer now. She had moved back home to Jamaica, and she has a whole charity called Feed the Fight Against Breast Cancer. These people live, okay? They're not in a hole somewhere. And some people just, there's some people who do all of that, and other people just go to work. Just like you and I, they just go to work, they raise their family, they see their grandchildren and their great-grandchildren, and they die of something else, but they don't die from breast cancer, because cancer is not the number one cause of death. Even though breast cancer is the second highest cancer death, it's like when it comes to cancer death, it's like 7 or 8. Heart disease and all those other things, those are the ones that are all the way up there. Cancer is like in 7th place when it comes to dying, even though we treat it like it's in 1st place. So people always have to remember God is in control. And I always have to remember this, because years ago I was at Allegheny East Camp meeting, and Dr. Benjamin Reeves, some of you know who it was, he's passed since then, but he preached a sermon on trusting in God's providence. And just briefly, what the sermon was about Peter in prison. James had been executed and Peter was in prison. And the whole point of his sermon, you have to trust in God's providence. When you read that story, Acts chapter 12, you read it. Any version you take, they said the angel said they had to shake Peter, they had to strike Peter. Peter was fast asleep, chained between 2 Roman soldiers in the back of the dungeon. And he was fast asleep because he realized that God was in control. He wasn't trying to fight it. Even though the people came to be praying for him, when he got out, they were like, no. They told the little girl she's crazy, right? That's what they told Rhoda. One of them even said, oh, maybe it's an angel. You know how stupid that is for a Christian to say that an angel is coming instead of the person? Because the only angels that do that is demons, when they tell you that your dead person is back there. But this is what they said to her. Read it in Acts. Even the church didn't believe that. That's another sermon in itself. Why are you praying? But the fact is, Peter believed that God was in control, and that's how he was able to sleep. When something comes, you have to remember that God is in control of our lives. So we're going to pray. We're going to claim the promises. Some of us, like Hezekiah, God will give us 15 years or more. And we need to do the right thing. God didn't bring us here, medical professionals, so that everything else you come to us for and you trust us, and then when it comes to cancer, somebody on the internet who you don't know more than us? Really? How does that work? God is in control. So my last words, Trust in the Lord with all your heart and lean not onto your own understanding. In all your ways acknowledges, he will direct your path. You need to trust and open your mind to what God is going to do. This opportunity, this is what this is. This is an opportunity for God to be glorified. It's not woe is me. We have to remember, no, God says, I know the plans I have for you. Plans to prosper you, not to harm you, plans to give you a future with hope. This word was said as they were being taken away barefoot and naked into captivity. And this is what God says. Okay? So we have to know that God is he has a plan and peace. You will keep him in perfect peace whose mind is stayed on you because he trusts in you, because the Lord Jehovah, verse 4 says, he is our rock. If we're not trusting God and we can't have his peace, I don't care what you do, you'll never be healed. And this is how we're going to take care of breast cancer or anything else that comes our way. Thank you very much. And I will turn it back over to Ms. Emlyn or Dr. Jennifer. Hey, Christine.
Thank you so much, Dr. Sinclair. Thank you. You know, I take courage in what you just said. When, you know, breast cancer, 17% of the, you know, patients actually, you know, will die from breast cancer compared to, you know, the majority surviving. And that is so encouraging. So we just need to take heed of what Dr. Sinclair just presented, get our mammograms done, get checked. If you do have a lump, make sure you get further testing done and make sure that you know, follow through with your doctor. So very important. At this time, we're going to open up the floor for questions. If anyone, you know, have questions for Dr. Sinclair, this is the time you can ask your questions. Ask your questions. We have a Dr. Sinclair. I forgot to tell you that she's a surgeon and she works with patients with cancer, breast cancer. So she's well informed. Anyone have any questions? You can ask your questions.
I'd also like to say hi to my sister, Debbie, who is online.
Hi, Debbie.
Lenore, do you have your hand up? You can also put stuff in the chat.
Yeah.
I
Lenore,
see Lenore.
you're still muted. We're not hearing you.
Can you hear me now?
Yes.
Yes.
Yes. When it comes to cancer for men, how do they do the testing? Do they do ultrasounds or MRIs or what?
We do everything. Sometimes we even do mammograms.
Okay.
But we definitely do ultrasounds. Most of the time with the men, we're finding a lump because of course there's no routine mammography. It's not common enough for that. One of the things I say whenever I give these lectures is that as a man, if you notice a lump in your breast, it is not okay. You know, you didn't hit yourself accidentally when you were moving furniture. No, the softball didn't hit you in your chest when you were playing with your children or grandchildren. Those things go away in a matter of weeks, right? If you hit yourself, if you're hit on the car door, whatever, those things go away in a matter of weeks. It's been a month. If the thing is still there, you need to get it checked out. Because there are other lumps, like even some benign lumps like lipomas, which are fatty tumors, they can occur because breast is really a specialized, biologically, it's a highly specialized skin. So anything that you can get anywhere else on your skin can occur in your breast, and many of those are benign. But if you have something there, it's been there for a month, it is not okay. And it can't, I don't care what explanation you have. I've even had one of my patients many years ago, and you know, even we treated her, she did well for a while. Unfortunately, it did come back eventually because she had it so long and she kept saying that she kept thinking that it was something else, but she knew it wasn't. And she finally came in and we were able to take care of her. She did get many, many years, but you know, she finally did succumb to it. Mm-hmm. So if you feel a lump, and a lot of times here again, the women, you know, back in the day before mammogram, it was the men that were the diagnosticians for breast cancer during intimacy. So now the women, you know, your dad, if you notice something, your husband, if you feel something, you know, it's not okay. And don't let him give you any explanation. No, he needs to go and get it checked out. then it will be okay. And yes, I have several patients with breast cancer, male patients.
Thank you.
Mhm.
Dr. Sinclair,
Yes. Hey, Miss Christie.
hi, Dr. Sinclair. And for men with like fatty breasts, is there a higher risk for them?
Yeah, the risks are the same, obesity, because what happens is estrogen is made in fatty tissue as well as in our ovaries. And so men do make a certain amount of estrogen, just like a woman do make a certain amount of testosterone. These are the male and female hormones. So of course, when men are fat, it's not just because they're fat why they have breast tissue, it's because in the fat, estrogen is being made. And so that's why they actually develop breasts. And so yes, they're at higher risk because, like I said, one of the biggest risk factors, controllable risk factors, are high fat diet and obesity. And it goes for men and women.
Mhm. Dr. Sinclair, from what I understand, you're saying that women with ovarian cancer can also, the chances for developing breast cancer is also very high. What about men with prostate cancer? You know, is there a higher chance of developing breast cancer? And I guess you also followed that up saying that these, the families who have breast cancer, the first generation, like the daughters or mothers, need to check regularly for breast cancer. So can prostate, so in the opposite, if men have prostate cancer, should their family members, like the daughters, also get checked for
Well, with prostate is
prostate?
different because men, everybody have breasts. Breast
Right.
is a sign that you're a mammal when it comes to biology, but only men have prostate. So there's a couple of answers to your question. One, there's something called Lynch syndrome, described by Dr. Lynch. And it is breast, colon, and lung cancer. It's a cluster. Or prostate, colon, and lung cancer. It's a cluster. And that is actually genetically transferred as well. Breast cancer and ovarian cancer, the same gene that increases your risk, the same BRCA gene, it's for both. We talk about breast cancer all the time, but it's actually for both. It's both for breast and ovarian. Now, if you're a male and you have the BRCA gene, you can pass the gene on to your female offspring, but you yourself can only get breast because men have breasts. We can never get prostate because we don't have prostate.
Right. Yeah, that was my question. If
Yeah.
they may, yeah, that was my trying to ask.
Yeah, but he can pass on the
Pass
gene
that gene
to
on.
his daughter because it's a genetic transfer. And you know, it's 23. The reason they have this thing called 23andMe is because it means you get 23 genes from your dad and 23 Ds from your mom.
Okay.
Okay.
Oh, someone wants Debbie.
Oh,
If
that's
you
my
want to
sister. She said she was trying to unmute to say hi
unmute.
back to everybody, but she couldn't
Okay.
unmute, so she put
Okay.
it in the chat.
Oh,
That's my
okay.
sister.
Oh, she said hi, sis. Okay, I got you. I was just trying to tell her how to unmute. Okay. Okay. Very, very informative. Anyone else?
Sister Marlene,
Marlene.
you got to unmute, sweetie.
For
There you
me,
go.
I've always been looking at this. I had that mentality that if I get cancer, I'm just going to play it out. And when the Lord takes me, it's time to go. And my son, you know, Michael, he used to say to me, why do you think God gave doctors intelligence and all the research that they do? That's why they're here to help you. You know, we've always had that conversation. And I would say, no, I eat, I exercise, blah, 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 blah. And but listening to your thing today, it turned me around completely to the point that I really understand now that it's a cancer. And like you had said, it's like being shot. if you don't take care of it, it's going to hang around. My sister-in-law had breast cancer when she was 50, and she would do nothing. She just did all the juicing and things like that. And she did live 10 years, but she lived miserably for 10
Yeah,
years.
it's a horrible death. Horrible.
Yeah,
I tell people that all the time. It is
Yeah.
a horrible death.
Yeah,
It's
and the
better you get hit by a bus. It is a horrible death.
And the doctor had told her it's so small, you can have the surgery and it'll be over. But she never listened. And so, you know, she died a young woman. And she used to say that she really was a good Adventist, and she went to all these places to do the cleansing and everything, but she never exercised. And she admitted that. And I thought, well, maybe that's what was missing. But now you've turned me around. I understand a lot more now. If I'm going next week, I haven't had one in about 10 years. So, you know, whatever will be, will be. But thank you. This was for me today. This was for me today.
I'm glad.
I'm
I'm
glad
sure
you're
it
able
might
to
be in a
come.
nurse. I'm sure it might be in a nurse who'd get on you. That's her son. I'm sure he's been getting on you the whole
He does
time.
get on me. Yeah, he does. And I
Yeah.
agree with him.
I just want to say that I'm a breast cancer survivor. I'm going to call myself that because thank God I'm still here. I think it was at the start of the pandemic, Dr. Sinclair and Dr. Sankey had one of these programs. I think definitely not as many people were on as are on right now. But I listened to that program, and I think it was 2020, and I had always done my mammograms, but I had decided that since I'm always doing my mammograms, I'm not going to do it that year. And I listened to their program, and then I decided, you know, I better do it. And I did the mammogram. I did the mammogram that year, and I think it was in November. I was on a cruise, and they called me to say they needed me to come back in. And I'm like, well, I'm out on the ocean now. But anyhow, I did go back in. And the long and short of it is that they saw a lump, and I had cancer. And I had always thought, like, there's no way I am going to do chemotherapy, because just about everyone I know who has done chemo, excuse me, it wasn't successful, or they still died. So why go through all that? But it's funny because when I was told that I did have cancer, and it was, doctor said it was a triple negative, I never really thought about it. I just, you know, said, you know, I'm going to go through and do what I needed to do. And Dr. Corleen was my surgeon. And I, you know, just thank her so much for the care, the loving care that she gave to me. And I went through the chemo, which was a horrible experience. And after the chemo, I did do radiation, and thank God I'm doing well. I go every 3 months to get blood work, and you know, for them to check my markers. And so far, so good, thank the Lord. And they said I think I have to do this for like about 3 years. I still have my port in, you know, but I go in and get my markers checked, and praise God, you know, he's been good. And there are some residuals from the chemo, which is some neuropathy problems. However, I am able to walk, I go to church, and thank God, you know, I'm still able to live a reasonably good life. And I am encouraging everyone to do get their mammograms and not put it off, even if you have been doing it all along every year. Don't skip a year, because if I had skipped a year, then it would have been a serious problem. So I thank you for this program, and please continue to spread the word, because each time it will help someone who does not know or who have not heard about what they need to do. And, it is a blessing. So thank you very much.
Mhm.
Thank you so much, Christine, for sharing that wonderful story.
Sister
Thank you.
Evelyn, just give me a
Yes.
moment to talk about triple negative.
Yes.
Because triple negative breast cancer, before we used to just do a couple of tests. Now we do a barrage of tests on the specimen. And triple negative is really a misnomer, because it means you're estrogen negative, progesterone negative, and HER2 positive. Those are the most aggressive cancers. So even though you may have a tiny little cancer like Sister Christine have, we have to treat them aggressively. If we don't, it's going to come back, always come back worse. Here's the unfortunate reality. It is much more common in women of color, particularly Black women. So my sisters, it is more common. It is what it is, okay? It's not just like how the Caucasian folk get skin cancer. We don't get it very rarely. The triple negative is much more common. And that's one of the reasons why for years, the results for Black women, even when you match it age for age, stage for stage, was not as good. So I'm glad Sister Christine, we didn't plan it. I didn't even know she was going to be on. And I'm glad she talked about it, because it is very prevalent in our population. And can I tell you this? I was a resident at Howard. And I remember saying to some of my superiors, I said, something is not right. Why the Black women are not doing, why we have all these Black women who are getting cancers in their 40s or early 50s as opposed to, and they said, you're at Howard, you're in DC, you're seeing mostly Black women. But something in me told me it wasn't a coincidence. I didn't have the ability to start a study. I didn't have grants. And I went into trauma for a while before I came back in private practice. And lo and behold, it has been proven that it's not just the size of the cancer, but triple negative. And yes, it's more common in Black women. So if you wonder why you have this tiny cancer and we're telling you have to get chemotherapy, and somebody else had a lump and they don't have to get chemotherapy, it's because we know we have to do more in order for you to be alive and well. And she's right, chemotherapy is not easy, but she's not the only one I know who had chemotherapy. Some people have some slight effects, some people have more effects, but I don't know anyone who, because of chemotherapy, they haven't been able to live a full life. I just don't know anyone who have, but I know way too many who are gone or who died in suffering because they didn't do anything. Thanks, Sister Emily. I just needed to say that.
Yeah, thank you. Thanks for sharing.
And there's
So
a question in the chat. Do you want me to
Yes.
address that?
Yes. What's the
Okay.
difference between chemo and radiation?
Chemo and radiation, big difference. Chemo is a body-wide treatment. It's called chemo because you're getting medicines through some sort of your vein, whether it's a port. Christine talked about a port. That's just an access into your main vein. It's a body-wide treatment. It's a combination of different medicines depending on your tumor, anything from Taxol to adriamycin. I'm not a medical oncologist, I'm a surgeon, but I do have some idea of what the medicines are. That's chemotherapy. Radiation is a localized treatment. You get radiation for localized cancer. What happens is when you have a lumpectomy, we know that, as I said before, cancer is like when a stone hits your windshield. You have that burst. Sometimes you can get spikes going all the way out. Even the most efficient pathologists cannot catch every little cell that might be out there. even though we do a good lumpectomy, so we get the core of it. So radiation is given locally in the breast to kill any little cancer cells that might be roaming around. And it's real. I've had patients who have refused it, and guess what? The cancers come back, and it's always at a higher grade than it started. So it does work. With radiation, you cut that risk down to less than 10%. Without radiation, you're looking at 35% recurrence, local recurrence. Radiation also used for patients, certain patients with metastatic disease. Sometimes breast cancer goes to its bone, lung, liver. Those are the three main areas, and sometimes brain. If you have a cancer, not just breast cancer, but any solid tumor, prostate is another one that's notorious to go to the bone or to the spine. You may get urgent radiation therapy to kill the tumor in that local area. It's not going to cure you because, of course, now the cancer is everywhere, but it can relieve the tumor in joints, prevent what we call pathologic fractures, which means that the tumor, so much tumor got to your bone that your bone is literally breaking like cornflakes. So by killing the cancer, it prevents that. By killing the cancer in the spine, it prevents the pressure on your spine. I know people who have had problems walking because the tumor has gone into their spine. We use radiation in the brain if the tumor has spread to the brain. So radiation is used for a localized area, whereas chemo is a body-wide therapy. So is hormonal therapy. It's a body-wide therapy.
Okay, thank you, Dr. Sinclair. Now, I want to let you know that tomorrow at the North Orlando Adventist Church, they will be doing that genetic testing. So those of you who are local can go to the North Orlando Adventist Church tomorrow from 8:30 to 10:30 a.m. They'll be doing that genetic testing. And I encourage everyone who can do it to go and get that test done. It's not invasive because I understand it's a sputum, it's a saliva, I should
Don't
say.
eat anything for 30 minutes before. Don't eat or drink anything for 30 minutes before. And you just spit in a little tube.
Yes, simple, easy. And then the results, I guess the results would go to the individual and then they would discuss
You're
it with
given a
their
card.
physician.
You can actually go online and get your own results. And the results also come back to my office. And also, if you're positive, they have a group of genetic, there are a few things that they do, this particular company. If you're positive, they will test your immediate family members free of charge, regardless of where they are. They're all over the country, so they don't have to be here in Orlando. And the other thing, if you're positive, they will do genetic tests, genetic counseling. They have people who are counsel genetics to say, okay, you're 30 years old, you're tested positive for BRCA, you're going to get breast cancer at some point in time, what an ovarian cancer, what should be the steps, what you should watch for, what additional tests you may need. So those are the two things. And yes, North Orlando, it's on Hiawassee. You can find it either through Google, go on the Southeastern website, or even the Adventist JC website that has a list of all the churches. And they, every fourth Sunday, they do a clinic. They were doing this all along. And now they've added genetic testing. It's for breast, ovarian, prostate, pancreatic, and colon. So if you have a family history of any of those 5 cancers, go there.
Yeah. Okay, so we're going to wrap up here. We're going to wrap up tonight. We want to thank everyone for coming, and thank you again, Dr. Sinclair, for such wonderful information. At this time, we're going to stop recording, and we are going to take prayer requests